Welcome, everyone. My name is Frank Brennan. I'm a palliative care physician based in Australia, and I'm very happy to be introducing the speaker today. This is the 6th Doctors Say No international webinar. And the Doctors Say No is an international network so far of 544 signatories from 19 countries to an open letter advocating that euthanasia and physician-assisted suicide are not part of medicine. We write that doctors should be left to focus on advocating for patients, to care sometimes, to relieve often, and to comfort always. Please encourage your medical colleagues to consider signing this letter. Before we start, just a couple of housekeeping messages. This talk and the other webinars will appear or have appeared on the, do appear on the Doctors Say No website. There'll probably be about a week's interregnum between this recording and this particular Doctors Say No webinar, but the others are there and will be there on the Doctors Say No website. Through this talk, the chat function is disabled. Throughout the presentation, please continue to write your questions as they arise on the Q&A tab. Dr. Sinead Donnelly, MD, and Dr. John Kleinsman, PhD, Aotearoa, New Zealand, are on hand to attend to your questions at the end of the presentation. So it gives me great pleasure to introduce the speaker. The speaker today is Associate Professor Natasha Michael, who works at the University of Notre Dame. She's also an adjunct associate professor at Monash University in Melbourne. Having trained overseas, Natasha came to Australia, and Natasha is a clinician researcher with research interests in many aspects, including cancer communication and the psychosocial existential aspects of cancer care. So welcome, Natasha, and we'll look forward to hearing your speech. Thank you.
Thank you, Frank. And thank you, everybody, for attending and for inviting me to present. So I'm a clinician researcher, so the questions that arise for me for research arise from what I witness in clinical practice. For example, if I note that pain is poorly controlled in a particular area, I sit with my research colleagues and we come up with hypotheses or research questions. And a key partner or a mentor for me has been Professor David Kassane. Many of you might know David, who really was involved in the development of the construct of demoralization, having spent 10 years at Sloan Kettering and now is working as chair of palliative medicine at Notre Dame. So many of the slides today that I use are shared between David and I, so I thank him for his assistance. My topic really arose out of a body of work that David and I have been conducting with our colleagues, including Xavier Simmons at the Plunkett Centre and a number of other colleagues across health networks in Victoria and Western Australia. It arose pre and post legislation around the issues of how psychoexistential distress contributes to a request for voluntary assisted dying, and then has evolved to a body of work that continues. And this concept of conflict of conscience, I will come to later on. I'm not a philosopher, I don't claim to be one, but I think my conscience is troubled really by things other than whether I should be involved in voluntary assisted dying. I don't believe I should, but there are other things that keep me awake at night. What we're going to do today is really explore some key research findings that have been undertaken by our group that have enabled us to understand the patient pathway to a request for euthanasia-assisted suicide, voluntary assisted dying, whatever you choose to call it. And more importantly, is to explore ways by which clinicians may enhance skills to assess and respond to a patient's request. And finally, then to consider accompaniment as a construct. And the second point, I think, is the main reason I chose the word conscience here, because I realized through working with patients when legislation came came into effect, as well as talking to colleagues, that many people simply did not know how to respond or did not have the skills to explore. And therefore, a patient naturally evolved into a path of voluntary assisted dying, despite this just being a query. So can we say no if we don't have the skills, right? So in the same way, can we say that a patient doesn't have a myocardial infarction if we haven't evaluated it, tested it, treated it? So is it appropriate for us to say this is wrong if we really don't have the evidence and the skills to put forward to a patient or a family? So any of us involved in this area now knows that everything changes and nothing changes. And really, legislation brings a common issue of a response or a query about a desire for death, or an expression of a desire for death, into a tangible reality. What we're facing in any country where legislation has become normalized is an increased number of inquiries about it, a lot of misinformation, and I'm sure many of you have experienced what we have, the taunting and threatening of staff sometimes, complaints and questions about the standards of care. And really, there is no room for complacency now. If pain isn't well controlled or patients are not well cared for, you can say, well, we have induced suffering, therefore it's understandable that patients might want to seek this. Our medical frame of reference has changed dramatically, as has policies and procedures. More importantly, there's a shift in the threshold of what is acceptable in medical care, and clearly a fracturing in the basic philosophy of what we're about and teams that have been created. And these challenges occur right across the sector, across all hospitals, aged care, community services. The demand that this is a patient's right, external influence, and many of us have experienced what we might describe as suicide under our watch, where these acts are occurring even in organizations that might have conscientious objections towards legislation. Fundamentally, many clinicians are unable to differentiate between a disorder of meaning or coping and a disorder of affect. So the difference between something like existential despair, a sense of pointlessness, a sense of loss of morale, mopishness, versus an actual clinical disorder of affect, which is depression, anxiety, grief, sadness. So there's a very significant difference between understanding what a loss of meaning is versus a clinical issue where your affect is affected, which can be alleviated with pharmacotherapy, psychotherapy, etc. I really want to focus around the concept of existential distress, which really is poorly understood by many, which is fundamentally a mental state arising from challenges to our human existence. Fundamentally, it arises out of our loss of control, freedom, autonomy, the loss of our individuality, meaning and value of life, and self-worth. And we know from the literature that disability, infirmity, importantly, influences of culture, religion, and ethnicity play strongly into these feelings of distress or experiences of distress, dysfunctionality within families, personality traits, embarrassment, shame, obsessional traits. Certainly, the issues of culture come to some work that we're doing in Singapore, where shame and stigma in many East Asian countries translate to high levels of active suicide, where people jump off high-rise buildings, etc., through the loss of role and therefore loss of meaning or purpose in their life. But fundamentally, existential loneliness is this sense of intolerable emptiness, sadness, a longing that results from an awareness of one's fundamental separateness as a human being. And I teach this to students frequently in a palliative care setting, that you might be surrounded by staff, you might be surrounded by family, but the journey that you face when you're facing a life-limiting illness or suffering is fundamentally yours and yours alone. So when does existential distress become clinically relevant? There's no concurrent consensus, but possible frameworks include when there is a preoccupation with thoughts of recurrence or progression that cause intense distress, when you have maladaptive coping, poor strategies that are adopted by patients or families, when daily functioning is impaired. I had a young patient recently who never left her room, really through terrible distress out of her very advanced illness and also trauma, suffered through traumatic marriages, and therefore a limited ability to plan for the future, what we call entrapment, right? Or described as feeling trapped or entrapped in a situation. So existential distress is distinguished from depression because in depression you have a state of anhedonia or lack of pleasure and a lowered mood, but this does not necessarily need to be present when one is existentially distressed. So you might see a patient who's has a reactive affect, laughing, able to engage with you, no evidence of clinical depression, but demonstrates high levels of existential distress. Yeah. So the conundrums we face as clinicians is how can we best support existential well-being? I use that term now, how do we promote psycho-existential well-being? Something we haven't thought about enough of in medicine. And does existential distress affect physical symptoms? The reality is it does. We know that patients who are severely anxious present with uncontrollable pain. And we see that when we don't see a correlation between what imaging shows, you can't correlate between what might be pathophysiologically present with what a patient might be complaining of symptomatically. We explore the existential issues. There's a lack of empirical attention to the ideas around existential loneliness and what are the psychosocial or spiritual interventions we should offer. What are the contributed factors to the unfounded use of deep continuous sedation or even euthanasia? And I see sedation frequently used in patients who are existentially distressed, and something we should question. People talk about intolerable suffering, but intolerable suffering is present if you don't know how to alleviate existential suffering. Your panacea must not be the use of sedation. So together with David Kisayan, a team of us developed something called the psychoexistential screening scale, or the PESAS. And a number of years ago secured a Commonwealth Department of Health funded a grant of over $1 million to roll out workshops across states and territories in Australia, to train staff and to use this screening tool to recognize and then subsequently manage psychoexistential distress. But the work around PESAS really started from David's early work on demoralization, 20 years of scholarship around the construct of demoralization. And we have a number of prevalence studies published internationally. The demoralization scale, or the DS2 now, has been translated, the initial DS scale, to over 30 languages. The DS2 is the shortened version that we developed and validated. We showed that a prevalence of close to 20% of palliative care patients are demoralized, and up to 30%, 35 to 40% of oncology or non-oncological patients suffer from a sense of demoralization. So demoralization is really a sense of hopelessness, helplessness, pointlessness, loss of meaning, a loss of purpose in life. And we know that patients who come from broken marriages or living alone or single with reduced social support, women with high symptom burdens and poor mental states are more likely to be demoralized than those who are in relationships or employed, who have a spiritual or religious focus in their life, who partake in exercise or activity and take a more hopeful approach towards life. These mediators and moderators are really important to recognize as sources of distress. So the positive signs, the plus signs demonstrate your moderators, the locks of support, resilience, religion can affect increased distress, the lack of them. Yeah, and the mediators, mediating, loss of meaning, promotion of meaning and self-worth mediates against suicidal ideation. hope, and shame promotes suicidal, loss of hope and shame promotes suicidal ideation. And these are just statistical variables that demonstrate to us, you know, the true regression analysis, the predictors of suicidal ideation, particularly in those who have many of the negative factors associated with it. Once again, this is Sophie Robinson's work that was published in 2007, demonstrating mediations for model of suicidality, depressive symptoms, meaning and purpose, distress and coping ability, and perceived control. Now, if you look at standard teaching in palliative medicine or the palliative medicine training programs, there is very little discussion or discourse around constructs such as this, meaning and purpose in life, distress and coping. These are constructs that we commonly discuss in psychology, psycho-oncology, psychiatry, but has been very poorly adapted in the palliative care setting. I will just talk to you a little bit about our work on the PESAS and share with you our findings. So the PESAS scale was developed just to look just like the SAS scale, the symptom assessment, or the ESAS scale, the Edmonton Symptom Assessment Scale. The ESAS or the SAS measures 8 to 10 physical symptoms, and in the PESAS we measure 10 psychoexistential symptoms that were developed out of the 20 years of work in demoralization. And against each of these items, we have synonyms. So you might ask a patient if they're anxious, or you might say, worry, do you feel nervous or restless? Many patients don't understand the construct of hopelessness, but they might understand, do you feel pessimistic, or do you feel you have no future again ahead of you? Trapped by illness, you'd be surprised to hear, was one of the most commonly reported symptoms, feeling stuck in the current predicament that they were facing, feeling blocked, unable to move forward. Yeah. So these are what pointlessness, no meaning, no purpose, no value in life. I've actually taken the PESAS work to Singapore, where we have trained over 90 staff in their National Community Palliative Care Service, and we've translated the PESAS into Chinese characters so they can be used across dialects, and also to Bahasa Melayu. We'll be running their first feasibility study in a few weeks' time to demonstrate cross-cultural use of this instrument. And as I said, this PESAS constructs were developed out of the concept of the work in demoralization, which showed that 80% of patients with severe demoralization demonstrated pointlessness, 70% feeling trapped, up to 80% a wish to die, a loss of control, hope. So we didn't pick these words out of the air. They came from 20 years of a body of work. Just going to demonstrate how a PESAS might be used in a clinical setting. When David and I train staff, we use the fishbowl technique, we use role-playing techniques, and we sit with clinicians in a room and we teach them how to ask these questions and how to use the tool effectively. I now use it routinely in my ward round when I feel this might be a patient who demonstrates signs of existential distress, or we want to pick up evidence of demoralization. And these are scores of a patient really who really struggled with pain, and despite the use of all of his analgesic medications, we were never winning. He was a sheep farmer who was dislocated from his usual setting, placed in a hospice alone, estranged from many of his family members. And you can see clinically, I felt he had an element of depression, and you can see how high his PESAS scores were. And I now work in a regional setting where there's a lot of social and financial deprivation, and I see very high levels of existential distress. This is what we call a network analysis, where we use specific, very advanced computational techniques to look at the correlations between these PESAS items. The thicker the line, the stronger the cluster. So you can see that pointlessness, hopelessness, entrapment, wish to die, loss of control, loss of role, and entrapment, discouragement, anxiety, depression, right? But importantly, this concept of loss of meaning, loss of purpose, very strongly related with a wish to die. This is just another version of Sinead would know through her work many, many years ago about physical symptom clusters. And you can describe this as psychoexistential symptom clusters. So we looked at data from 1,405 patients across Australia, and we found that approximately a third of them had symptoms of anxiety, discouragement, feeling trapped by illness, loss of control, and loss of role. Approximately a fifth with depression and hopelessness and pointlessness. So high scores across a large cohort. And this was published in the Journal of Pain and Symptom Management as companion papers. The second paper was looking at a change longitudinally. So we looked at 319 patients where we had recurrent PSS scores at T1 and T2. And we demonstrated you could see an improvement in the scores, but the improvement was most marked in patients who had severe scores of 8 and greater. These are just preliminary findings. We have a lot of work to do to continue this work internationally and also across the Australian setting. We're now doing the PSS study using the PSS tool in a study looking at the correlation between existential distress, symptoms of anxiety and depression, and measuring a desire for haste and death. And a second study looking at the PSS score specifically in patients with pancreatic cancer, where we know there are high levels of clinical depression. This is an important slide because what we did was we measured the 204 clinicians who took part in these training programs over 21 workshops. We measured their confidence pre-training and post-training, and more importantly, we look at their Cohen D scores, right, which is the effect size. And you really want to look for an effect size of greater than 0.8 is a large effect size, and you can see significant improvement in confidence in managing distress, diagnosing a psychiatric disorder, assessing suicidal symptoms, assessing existential symptoms, psychological symptoms, etc. This came with a booklet which demonstrated, and quite a lengthy lecture to talk about the different constructs or the different clinical diagnoses of mental health disorders and constructs of existential distress. So this is what I talked about. Can we say no if we don't train our staff? If we don't have the confidence and the skills to help our patients, how do we oppose something that has become a tangible reality? I just want to briefly mention that we can't just not remember the importance of spiritual assessments that we do on patients. This was a spiritual concerns checklist that David and I developed and did psychometric validation on, and we demonstrated in a cohort of 260 patients fear of the dying process, fear of loss of control, regret of past behavior, concern about self-forgiveness. We also then measured things like loss of meaning, forgiveness of other, loss of hope, guilt of past behaviors. So there were religious-related items as well as more secular-related items. But this concept of self-forgiveness is something we never think about enough when we speak to our patients who've come from difficult circumstances, challenging backgrounds. This is a more recent body of work where, following the legislation of voluntary assisted dying, a number of hospitals across the Victorian network kept databases of patients who made inquiries about voluntary assisted dying. They didn't necessarily pursue them, but they inquired or they pursued them. And we then obtained ethics approval to look at the database of 5 hospitals across Victoria. And I encourage any hospital really to maintain such a database. I think it's important for us to continue to understand why patients seek this, what the outcomes are. And unless we look at data and follow through to outcomes, it's impossible really to fully understand what the underlying factors are. This study was funded by a Sydney Bioethics grant, and this was a retrospective study. It's harder to do prospective studies in this work. And what we did was we looked at 141 patients from the database. And in this case, even though there were 5 groups in the entire study, we only looked at patients from 3 participating sites. We de-identified them. We looked at, we developed a data extraction tool from the literature and based on clinical experience, looking at our national benchmarking symptom data, PCOG data. We looked at whether there was recognition of mental health diagnosis or symptoms. We sought to see if the reasons for seeking VAD was noted in the notes and the outcomes. And for each patient, then we developed a case summary. This turned out to be a mixed method study. We did manifest content analysis to analyze the case studies and then descriptive statistics. And we then benchmark against the 8 domains developed by the National Consensus Project for Clinical Practice Guidelines for Quality Palliative Care. I won't share all of the findings of this study. I'll share some of them with you. But we could see there's a mean age of 70, predominantly male, Australian-born, married, and non-religious, predominantly cancer diagnosis, and unsurprisingly professionals or majority, or managers and majority were in the deteriorating phase. A third had noted symptoms of anxiety, depression in their medical records written by clinicians, cognitive impairment, demoralization, and 10% had active attempts at suicide or suicidal ideation. 2/3 had at least one mental health issue, and approximately 4/5 had at least one moderate to severe physical symptom, based on the PCOG data that we had. We importantly tried to understand why they sought VAD, why did they make this inquiry? The predominant reason really was a desire for autonomy, but just over half described actual suffering. Existential or psychoexistential suffering occurred more commonly than physical suffering. Half described a fear of future suffering, and a 1/5 articulated a fear of burden or isolation. So almost half were motivated by a fear of suffering, and most also at some time had accompanying mental health condition or physical symptoms of discomfort. And this is a diagram that David Kissane and I developed, which I think is important because it demonstrates the potential pathways following a VAD inquiry. The top and the bottom ones are ones we commonly understand. Patients who are very receptive of palliative care, they develop a clear therapeutic alliance with us. They accept symptom control and the alleviation of suffering, and they choose to continue down the path of palliative care. The lower level that describes a commitment to VAD, there's a minority who belong to Exit International, Dignitas, etc. They proceed with VAD assessment. They're signed up years ago. They obtain the permit. They continue down the process. Majority of patients sit in this group, the uncertain or the ambivalent. And this is where the danger occurs, right? Because they fluctuate, they oscillate between exploring palliative care and exploring VAD. And really, it's the skill of the clinician that is critical here in this ambivalent group, right? Also here, because you can have somebody go down this path and then choose to go down this path if existential distress develops. But to me, the lack of skill is most commonly seen here. When the patients come, young doctors come to me and say, Natasha, the patient's looking for VAD, when actually the patient's just expressing an expression of suffering but it's directly translated to a request for VAD, and therefore we must make a referral to the VAD coordinator, and therefore the paperwork is put in front of the patient, etc. No formal assessment done for existential or mental health conditions. So we followed on this work by looking at the case summaries that we had and selectively sampling a cohort of caregivers whose patients had died from voluntary assisted dying. That paper has gone into Journal of Palliative and Supportive Care, and I hope it'll be published before the end of the year. But what we found really with the caregiver work was that caregivers coped by reframing their thoughts. So many caregivers were affronted by the patient's request, but in order to cope, they used words like, this was an act of bravery. He was an exceptionally brave man. They sought external validation and affirmation. All the friends and family said it was a lovely thing to do. You did the right thing. They argued the patient's right to choose. It was what my mother wanted. It was her decision, her life. They sought to self-compassion. They sought self-care and self-compassion. I wanted it for him. It was about him. My feelings didn't matter, right? They sought closure and preparedness for death, right? We used it to our advantage because we did get to say goodbye, and we needed, and what we needed to say. They reframed it by saying, well, actually, he didn't die from VAD. He died from his cancer. And this was a reward for their caregiving, right? Although I was upset, it was a beautiful journey as well, because I felt I was doing something important for another human being. And it eased their suffering. I'm a Christian. I look at our loved ones and I see them suffering. I feel, well, why should they suffer like God on the cross? This was an ease of their suffering. I found this caregiver paper very difficult to write because the caregivers argued very much for support from us despite our opposition. They wanted to be accompanied. They understood where we came from, but they sought to be understood themselves. And as researchers, we have to be truthful to what's difficult. Even though I am not a supporter of VAD, I have to be truthful to the data. I found this very difficult reading and very difficult writing. You might be aware, some of you, of Emmanuel Levinas. He's a French philosopher, and he writes about this concept of useless suffering and compassionate asymmetry. As I said, I'm not a philosopher, but I sometimes dip into reading these things because they make me think differently. And he describes this asymmetrical configuration of the uselessness of suffering, that while the others suffer, well, the other suffering must remain useless to me, my suffering in response to the other's suffering can be useful. I use the term reciprocation of care. That's my simple human language. But suffering, you can argue, is useless, but suffering can be of benefit if we learn how to reciprocate and understand this construct. As one of my PhD's papers was writing about this posturing of vulnerability and resilience. When I recognize as a clinician that patients oscillate between these stances of vulnerability and stances of resilience. And our error as clinicians is we always focus on the vulnerability and we fail to enhance the resilience. So an example would be ambivalence and acceptance of death. Yesterday, I don't want to die. Give me some more chemotherapy. Tomorrow, I'm planning my funeral and writing my eulogy. Concern and grief versus courage and confidence. Loss of role. I've lost my role as a mother, but I'm able to do legacy work. I'm able to plan for my child's future. I'm able to direct what's left of my life to a sense of other. So give you a simple analogy. When the registrars come to me and say, Natasha, I don't think so-and-so can go home because they can't get out of bed, they're very breathless, and They seem a little bit anxious. I say to them, now give me 3 reasons why they can go home. The family's always present, they're extremely cohesive, and they're very accepting of palliative care. So how do we harness what's positive about this family rather than focus on the negative? How do we enhance resilience? How do we harness resilience? How do we encourage coherence, purpose, and significance of life? How do we instill a sense of security through emotional and moral solidarity? So this sense of accompaniment is an interesting concept, and it came across really strongly when the caregiver interviews were read. And people make a misconception of thinking that VAD is just about when death occurs. VAD in the construct of accompaniment starts from the point of initial request, having to sit and stay with the patient right through the caregiving process, prior to them even attempting it. And it's this accompaniment that can change their mind, right? Being present with them. I had to deal with a lot of my emotions, my reactive emotions, because I couldn't accompany when I was reactive. It took a lot of pulling back, stepping aside, learning how to self-manage, to say, right, I've just got to be present, knowing that my presence can be the thing that might shift somebody towards thinking differently. Sometimes people take the drug, and I've certainly had this experience, they don't die with it. The death is delayed. They might need a syringe driver, or I can tell you some terrible stories, but this is not the place for it. And then most importantly, how do you accompany without judgment after death into bereavement? I mean, I'm not making ease of this, right? I'm not saying we should say yes. I'm saying we should still say no. But in the tangible reality of what's happening now, what do we do with these patients? Do we abandon them? Or do we continue to accompany them? I still see patients who I know are going to pursue VAD, who have the drugs in their house, who I know are going to have the appointment tomorrow at 3:00, because I am hopeful that my presence and the care that I provide can be the mediator that makes them progress through a path of natural death. So non-abandonment is a central ethical obligation. Importantly, it's a longitudinal commitment, both to care about the patient and we jointly seek solutions to problems throughout their illness. Non-abandonment places us as clinicians towards an open-ended, long-term caring commitment to joint problem solving at the core of medical ethics and clinical medicine. There is a world of difference between facing an uncertain future alone and facing it with a committed, caring, knowledgeable partner who will not shy away from difficult times or difficult decisions when the path is unclear. Yeah? So we continue to say no, but we don't abandon. And we don't get implicit in the process. So when I train staff, they say to me, well, what do we do, Natasha? I mean, how do you provide this meaning-centered care that you talk about? And I commonly draw this diagram for my patients. This is where you are. This is your horizon. The only difference between you and me is your horizon's visible and mine isn't. All the treatment your doctors give you now when you're in an advanced stage will only do this to your horizon. Sometimes when you're very sick and you continue with treatment, it can do this to your horizon. But what you fail to recognize is this is what you can truly influence, how you live your life between now and the horizon. And I love it when I get the postcards to say, thank you for the horizon diagram, Dr. Michael, we're in Port Douglas. Or I say to them, bring me a fridge magnet back after your trip to New Zealand. So this is what we offer patients: biography writing, volunteers, dignity therapy, meaning-based therapies like map therapy, legacy leaving, reminiscent work, preparation for that, emotional, spiritual, values, reconciliation, thanksgiving, seeing to legal and financial matters, getting your affairs in order, preparing your children, your grandchildren. Importantly, the care of the body, preparing for a funeral, bereavement care, all of these things can actually enable us. They're practical things that we must put forward, offer our patients, not simply talk about no to VAD. Do we make and do we offer this to our patients? And I think I just want to end by talking about the concept of moral courage, which I don't have to talk about really, because many of you here, I think, have it. But it's increasingly necessary when many of us have faced threats to reputation, shame. We have experienced emotional anxiety, isolation, colleagues, retaliation, the risk of loss of employment. But we are able and prepared to face tough decisions and confront the uncertainties associated with their resolve to do the right thing despite consequences. I found the most important thing I can do, other than be with my patients, is develop relationships with colleagues, even colleagues that I don't share a viewpoint with. That I demonstrate what I can achieve as a good palliative care clinician towards the care of their patients. When I complete a PESAS questionnaire, I actually send it to them. Even if I know a patient's seeking VAD under their care, I complete the PESAS and I say, and send it to them, and I just share the story of this lady. Look at a PESAS scores. The greatest fear is, how her elderly husband's going to care for her. That's the greatest motivation for seeking VAD. And actually, to resolve this, we have had conversations about her ongoing care in an aged care facility or her ability to stay in the hospice, right? You've got to share these stories with your colleagues. So I end there. It seems like a slight paradox of what I intended to talk about and what I ended up speaking about. But to me, the conflict of conscience arises always when I ask myself, have I done enough as a clinician? Have I adequately assessed, treated, managed, responded to my patients prior to them seeking assisted dying? So thank you for listening.
Thank you so much, Natasha, for that excellent presentation. So I might then turn to Sinead and John to see if there are any questions.
John, if you want to start.
Yeah, we have a number of questions here, Natasha. I'll start with the first one, which is from Mark Comrade, actually. And he writes, in the US now, 8 hours of opiate training are required to get or to renew a license to prescribe controlled substances. And his question to you is, have you advocated for either special licensing to evaluate patients for VAD and prescribe lethal medications in New Zealand that would mandate training in your excellent methods of assessment?
That's a terrific question, Mark. At the moment, the legislation demands that you complete a VAD module online. It does not involve any form of training in existential issues, mental health issues. I have presented this data at Notre Dame every year with the medical students. We have a VAD session where we have a pro and an anti-VAD doctor there, and it can be quite confronting. And really what we want to do is to encourage respectful dialogue and get the students to really think about these things. And this has actually come up by the pro-VAD doctors who agree with me, who say, actually, we should train staff. We should maybe consider, that these assessments should occur. I think the challenge for us will be the political climate and the pro-VAD advocacy climate that might push back against it. There are many other challenges that we face, but I think that's excellent. That's a great idea.
Thanks, Natasha. And another question from Ferna Pisi, that they have observed the distress of a Christian healthcare giver working in the community whose patients choose VAD. What support can we give to those healthcare assistants?
Yeah. So Ferna, I commonly get phone calls from Christian, Catholic, Buddhist workers who, they ring a number of us clinicians where they work in organizations where they're asked to, say, for example, develop a care plan. A nurse rang me recently to say, I have to develop a care plan. What do I do, right? And the challenge in Australia is you cannot be seen to be obstructing the process, right? So I always say to them, enter the meetings, because they usually are holed up to some kind of a meeting. Enter the meeting with a solution. Ask that your conscientious objection be respected because the law allows for that, right? Don't go in with an argument. Go in proffering a solution to say, I will continue to visit this patient, I will continue to care for this patient, I will continue to accompany these patients. These are the things I find difficult. Can you propose a solution to me? So you ask them to give you the solution. So you're not saying, I'm not going to do this. You say, can you give me a solution? Because I'm a conscientious objector and I cannot partake in these things. And I can tell you, every single nurse, they've also far been nurses, has come back and said to me, yep, it's worked, right? I think it's harder when it's done in a palliative care unit and nurses are caring for patients in that environment. It can be very distressing. And I think you must offer the right kind of support and counsel and reassurance to the nurse about, how far do you go? How far do you have to go before you become morally complicit in a process? And David and I were involved in writing the bishop's document around providing support to pastoral practitioners who seek VAD. And where do you draw the line? Yeah, these are difficult discussions to have. Does the fact that you continue to visit a patient at home but not partake in the process, does that mean you're complicit? I don't think so. I think it's worse off if you abandon your patient. So I think you've got to provide some level of counseling and support. Sorry, Sinead.
No, that's great. That leads into another question, which is, you probably have answered there. Another attendee said, some argue that we are complicit should we choose to be in the room at the moment that assistance in dying is administered. What are your thoughts about this?
I don't. I'm never present during the act, and I discourage anybody who's a conscientious objector to it. I discourage them from being present. I think it's very difficult to be present. Yeah. And people even ask people have asked me, can I attend a funeral? This is the question again, where do you draw the line? But I think being physically present during the act is something we should all try and avoid if we are conscientious objectors.
There's another question here, Natasha. The head of dying with Trinity Quebec is a neurosurgeon who speaks publicly about existential distress as a reason for MAID or assisted death, but probably has no idea what to do about it besides ending the patient's life. How do you respond to that?
Well, you can simply ask him the question, how do you treat existential distress? You can ask him, are you aware of meaning-centered interventions? Are you aware of calm therapy? Are you aware of dignity therapy? Are you aware of MAP, meaning and purpose therapy? Clinicians aren't aware of these things unless you work in the area of psycho-oncology, palliative care. You're not exposed to these interventions.
And Natasha, thanks, Natasha. Another question from the same attendee, that they read an article in the New England Journal of Medicine about conscientious objection that said the doctor's objection should only be accommodated if the patient will not be harmed or lack necessary care. And the attendee said they don't seem to understand that there are differing views of what is good for the patient. You want to comment on that, Natasha?
Yes. I think I come back to this question of has the patient been adequately assessed, right? So if you have not assessed for existential distress, if you have not assessed for spiritual doubt or lack of spiritual support, how do you know that the patient's been adequately cared for? Your assessment is incomplete. We would never stand before a court of law and argue if we had done something medically incomplete, we would be held liable. And yet, when we're incomplete in our psychological and emotional assessments, we're allowed to, those things don't ever come to the forefront.
So, sorry, Natasha, there's another request from Catherine Ferrier. Could you share the bishop's document that you helped write?
Yes, I can forward that to Sinead and John to put on the website. Yeah.
Natasha, I've got a question, a personal question.
Yeah, there's a question here from Mark Comrade as well. Can I take that and then come to you, John?
Sure.
Sitting there for a while. Do I offer it as a treatment option under the rubric of palliative care? No, I don't. And I don't ever think it should be offered as a treatment option. I know one particular doctor that who says to the patient, or you can choose not to have any more chemotherapy, just have palliative care, or you can also have VED. The law in Australia doesn't allow it currently. It is not a treatment. Yeah. Sorry, Jonathan.
No, that's fine. Look, my question related to a comment you made earlier on in your presentation about social and economic deprivation being indicators of psycho-existential distress. And I just wondered whether you might elaborate a little bit more on that. It's a critical question here in our country, particularly where the local tangata whenua, the Indigenous people, are overrepresented in the statistics surrounding social and economic deprivation. So I was particularly interested in that, Natasha.
So we've been doing some work with, his name is David, David at the Anscombe Bioethics Centre. What's David's?
David Jones.
David Jones, right. And his data from work in Oregon is fascinating to look at. The main increase in trend over 20 years is financial concern and burden, right? That's the main reason for people seeking VAD now. It's completely understandable when you think of the cost of care, right? To care for somebody at home in this climate, how do you do it when you have two parents, two children working? 24/7 care in the community costs $4,000 to $6,000 a week with private carers, right? Many people in the areas that I work in don't even have family homes. They live in social housing or rented accommodation. So it's easier to die than to face all of the stress of this uncertainty. What is our government? What are our policy responses to this level of social deprivation, right? We are facing issues of social affordability, housing, lack of housing. I see this all the time. It's a terrible pain, and I have actually even challenged groups, not-for-profit groups. The amount of access that is available in central metro compared to rural or regional areas is shocking, the differential. If I continued to work in my previous place of work, I could think of 6 places I could send these patients to. I can hardly think of one up in a major regional cancer center because the Anglican Church is not present, the Catholic Church is not present. We are present, but only in small community groups. We don't build the infrastructure, right, that are needed, and there are multiples of in major metropolitan centers. So not-for-profit groups have a lot to think about in terms of expansion of their boundaries outside of major areas, metro areas.
Thanks, Natasha. I have a question. It's a technical kind of question in relation to your research. You used a hospital database. You were saying for access about retrospectively, I think it was that study. How did you get access to hospital data on patients who had voluntary?
All of this through the ethics committees. All of these hospitals kept a database. It took me 18 months to get ethics approval.
It was difficult. I'm just checking, even not before you get ethics, just to get access from the hospital.
You can't get access unless you get ethics.
But when you got ethics, you got access. Yes,
but very true, a very complex process. So it was de-identified, only relevant information. None of the data was given to us. Our nurse went across to each site only to extract relevant data. Everything was redacted. So information that was shared with us was completely de-identified. So if we went through medical records, they were completely redacted before. So we didn't know whose data we were looking at, right? Yeah. So it was a lot of work and a lot of time. People underestimate how much effort and time it takes to do this work, but yet the importance of it and the funding that is required and how we try and source. We do a lot of work with very little money. Really, a lot of committed people. I take my hats off to them.
And I have one more question. There is a Q&A, but it's just from Dr. Collar in Ireland, from Miriam's asking.
Hello, Miriam.
Yeah, will a recording be available? And there will be a recording. It will be approximately, as you were saying, Frank, in about a week's time. Can I ask one more question, Natasha, because there isn't, and then hand over to Frank. You were saying about your study on clinicians' confidence pre-training. I think that was in the training for the assessing.
For PESAS, yes.
That's right. But do you do your skills training about the intervention once you identify the existential distress? I mean, what's the skill level of pre and post intervention? Like,
Yeah,
they can now
I don't know.
assess.
Yeah. I don't know yet, Sinead. And, you know, my question is, how do we get this sort of stuff into the NSPAM training programs, right? I can't even get it through our Victorian training program. There isn't enough awareness about how important it is. And every registrar that comes to my service now, I train them on the PSS and they do it, right? It's not difficult. They watch me do it once or twice on the bedside and and now they get, Natasha, look at the PSS scores, right? Because all of a sudden they realize actually they've been trying to grapple with something, but they've been barking up the wrong tree. So it's not difficult to do. It's now incorporated into PALCare. So any organization, many New Zealand community services have PALCare. The challenge David and I face is really there's two of us, one retiring, one getting older, trying to promote this work. The Singaporeans have taken it like fish to water. It was unbelievable working with them. I'm so excited to see what they do with it because I think it'll be they will champion me taking it to the next place. Yeah.
I'll hand over to Frank.
Thank you, Sinead. Look, on behalf of the organisers of this webinar and also the participants, the people who've come online and those who'll hear this recording, thank you so much, Natasha, for this very interesting and stimulating talk that you've given today. Thank you.
Thank you, Frank, for the opportunity, and Sinead and John. The pleasure has been mine.